Hello, everyone. My name is Tashara Moffat. I'm a Senior Program Officer at the Center for Healthcare Strategies and use she, her pronouns. I'd like to thank you for joining today's webinar, Meeting the Health and Social Needs of LGBTQ+ older adults through Medicaid in California and nationally. I'd also like to thank the California Healthcare Foundation for their support of this webinar and related work. Next slide. Our goal for today's session is for participants to come away with a better understanding of the unique needs and barriers LGBTQ+ older adults face related to health, LTSS, and social needs, as well as how states such as California and Massachusetts have implemented state-level innovations to address the needs of LGBTQ+ older adults enrolled in Medicaid. Next slide. Our agenda for today will start with introductions, an overview of California's LTSS and social care initiatives under CalAIM, an overview of the unique health, LTSS, and social needs of LGBTQ+ older adults. Then we'll follow that with a panel discussion with our experts on how Medicaid can improve care for LGBTQ+ older adults, followed by a moderated Q&A. Please share questions throughout the webinar using the Q&A icon at the bottom of your screen. During our Q&A portion, we'll get to as many as possible. Next slide. Next slide, please. CHCS is a policy design and implementation partner devoted to improving outcomes for people enrolled in Medicaid. We support partners across sectors and disciplines to make more effective, efficient, and equitable care possible for millions of people across the nation, which aligns with our topic for today's session. Next slide. I'll quickly introduce our speakers. We have Carrie Graham, who's the Director of LTSS at CHCS, Matthew Fan, a Program Associate at CHCS, Jason Flatt, who's the Assistant Professor at the University of Nevada, Las Vegas, Kathleen Sullivan, who's the Executive Director at Open House San Francisco, and Sean Cahill, who's the Director of Health Policy Research at the Fenway Institute. And with that, I'll turn it over to our first speaker, Carrie Graham.
Hello, good morning or afternoon, depending on where you are logging in from. Thank you so much for joining us today for this webinar. We're going to start by just sort of grounding some of our conversation and some of the Medicaid reforms and innovations that are happening in California that we believe, have the potential to impact the health and social needs of all older adults, but also LGBTQ+ older adults as well. Next slide. So California has an initiative called CalAIM, and it's actually a lot of different initiatives. There are many things going on in California to try to achieve a few goals. So one is to provide more whole person care through Medicaid. Another is to address social drivers of health. And another is to try to reduce health disparities and reduce complexity. And because California is a big state and a lot of different counties, there was different demonstrations and initiatives going on in different counties. And part of CalAIM in California is to try to make it consistent across counties. There are 3 different initiatives that are part of CalAIM that I'm going to talk about that we think are particularly well positioned as a lever to improving care and addressing the social drivers of health for older adults. Those are enhanced care management, another one is community supports, and another one is the institutional long-term care carve-in. Next slide. Let me start by telling you a little bit about enhanced care management. This became a required medical benefit in 2022. And, many Medicaid managed care plans, most Medicaid in California is provided through managed care plans. That's the same with a lot of states. And most of them do some form of care management. Enhanced care management was really based on some of the lessons learned from some other demonstrations in California counties like whole person care, and health homes. But it is at the highest level of care management for a certain populations of focus. There are populations of focus in 22. It really started with the whole person care population, including people experiencing homelessness, people who are at risk for avoidable hospitalizations, people with serious mental illness or substance use disorders. And then, and this was the population that had been being served by whole person care management, for those of you from California who are familiar with that. And then in 2023, and other populations of focus were added, including adults at risk for institutionalization, for being institutionalized in nursing homes, people who are already nursing home residents who were transitioning to the community. So an interesting thing about enhanced care management is that it requires plans to contract with external care management organizations like CBOs. And what the CBOs do is they assess eligibility. Are you part of this population of focus, and do you meet eligibility criteria? Most of the eligibility criteria is really about high acute care utilization, or if you're at a SNF level of care. And then they provide the care management services. The cool thing about having the opportunity for health plans to contract with CBOs is that theoretically those CBOs can be closer to the community. They can have the cultural understanding and humility to provide services and care management to groups that maybe a higher, a health plan doesn't have that expertise. So that's really an opportunity. Next slide. Community supports is another initiative in California, and they're using a flexibility called in lieu of services. Many states use in lieu of services, but it's my understanding that California is the first state to use in lieu of services to provide sort of non-medical social care to Medicaid beneficiaries. So it's an optional benefit, it's not a required benefit, and Medi-Cal managed care plans can choose none or all of 14 different services. Some of the services they could provide are related to housing transition, navigation. They can do housing deposits. They can provide short-term post-hospitalization housing, recuperative and respite care. They can provide a nursing facility transition service, home modifications. They can do personal care, and they can do nutrition or medically tailored meals. So there's 14 different services they can choose from. Again, they're focused on populations of focus and have certain eligibility criteria. Like enhanced care management, plans are required to contract with CBOs for these, which is great. And many of the CBOs they contract with do both enhanced care management and community supports. To my knowledge at this point, I don't believe many plans in California are contracting with organizations that focus specifically on LGBT populations. And if I'm wrong about that, please let me know. Next slide, please. And the final initiative that's part of California's reform right now is called the long-term care carve-in. So before this all happened, about half of California counties, managed Medi-Cal plans did carve in nursing home care, whether it was through other demonstrations like the Coordinated Care Initiative or because they were coast counties. But beginning in 2022, all managed care plans began carving in nursing home care for their Medi-Cal members. And kind of like enhanced care management, they have to create a provider network of nursing homes. And it provides opportunities for managed care plans to be another level of oversight in terms of the quality of care that their provider network is providing. There's also a real focus on getting in CalAIM in general and making sure people are at the right level of care. So this really applies to trying to get people out of institutional care and being able, as the managed care plan, to coordinate enhanced care management and the community supports to try to, especially the ones on nursing facility transition, to try to do a better job in getting people out of institutions and safely into more community-based settings. So that's the hope, whether it's working or not. is not necessarily for me to say, but those are just 3 initiatives: enhanced care management, community supports, and the long-term care carve-in, that are levers that we have in California, and other states are doing similar things to try to improve care for Medicaid beneficiaries. Next slide, please. I also just want to quickly mention some protections for LGBTQ plus older adults in federal and state laws. First, in 1987, the nursing home reform law was passed at the federal level. And that basically says that anything that has Medicaid or Medicare funding, they cannot discriminate against people based on sexual orientation or gender identity. We just learned, and Jason just sent us an article that's coming out in the Boston Globe, that also is showing that several states, I think 5 so far, are recognizing families of choice for paid caregiver leave. So that's an exciting new development. And then a few states, California being one of them, I believe Massachusetts also, have LGBT facility, long-term care facility residence bills of rights. And this makes discriminatory actions a crime, and it gets a lot more specific than the 1987 nursing home reform law in requiring things like posting notices about discrimination, and the right of people to have their gender identity and preferred name and pronouns indicated on resident intake forms, and protecting personal identifiable information. So there are these protections in place. But today's topic is, how can we better use Medicaid levers to improve care for LGBTQ plus older adults, especially since in California, they're not named as a specific population of focus in any of these reforms. Next slide. All right, I'm handing it off to Jason Flatt, a researcher from the University of Las Vegas, Nevada, who's going to really center us on just what are some of the unique needs of LGBTQ plus older adults, especially those with complex care needs or needs for long-term services and supports.
Thanks so much, Carrie. Go ahead and go to the next slide. And I'll be talking with you a little bit, framing this really within the healthcare and social needs space for the LGBTQIA plus community. So next slide. So I want to go over some terminology. I'm going to talk with you a little bit around inclusion and why that matters and what we're seeing in our country right now around LGBTQ plus rights. And then I'll share some of the current research with you. So next slide. So first, it's really important to acknowledge how diverse the community is. And here I'm just showing you sort of a list of words that are used to for some of the identities that represent the community. So when I'm using the term LGBTQIA+, I'm thinking about lesbian, gay, bisexual, transgender, queer, questioning, intersex, people that may identify as asexual or use another term that is not reflected here. So very diverse. It's really important, if you're going to work with the community, that you commit really to being culturally humble and learning and using language that the community endorses. So next slide. I really love this image here, the gender unicorn developed by the Trans Student Educational Resources Group, that really emphasizes that gender identity, gender expression, sex assigned at birth, and physical and emotional attraction do not fall on a binary, right? So we see all of these following on a continuum. In fact, we know that people are born with differences in their sex development, or intersex people. They may have differences in how their bodies respond to hormones, to their reproductive anatomy, or even their genetics, around 2% of the population. I also am including a Wordle to show you just the diversity in terms that people may endorse for their gender identity. And so a commitment to ongoing learning is going to be necessary if you work with the community. So next slide. So inclusion really matters. And what we're seeing across our country right now are attacks against the LGBTQIA plus community. And so we need communities to advocate. We need service providers to really think about ensuring their staff are trained and that their services are truly welcoming. So next slide. So at the top, I show you just a very brief timeline of what we've seen, especially when we think about working with LGBTQIA plus older people in terms of their access to equal rights. So prior to 1969, many LGBTQIA plus people experienced harms. Things like it was illegal for you to dress in gender affirming clothing. You often would see LGBTQ plus establishments being raided by the police. Historically, in terms of where we see for LGBTQ plus people and why they may be reluctant to seek out healthcare, especially mental health care, is that their identities were considered a health disorder in the DSM. So it wasn't until 1973 that identifying as a homosexual person was no longer considered a mental health disorder. And we still see, in order for transgender and gender diverse people to receive care, they need a diagnosis of gender dysphoria. They actually called this a gender identity disorder up until 2013. We see here also currently I show a map that keeps getting out of date, unfortunately, of attacks against transgender youth in terms of their access to affirming healthcare. So you can see the states in orange that are banning access to care. We actually are seeing that these laws are being expanded not just to youth, but to all adults. So we know historically the community has not had access to the same rights, specifically protections around things like employment, housing, and healthcare. And we see that this is even more of a concern for those who have intersecting identities, such as people of color, people living with HIV, or maybe living with a disability. So next slide. So here I want to frame to you sort of the unique concerns for the LGBTQIA plus aging community. We know this population is growing, especially as we see the shifts in our country. We know that at least nearly 3 million people in our country identify as LGBTQIA plus and are age 50 and older. More than 1 million of them are 65 and older. And as I had mentioned before, the community is very diverse. At least 1 in 5 identifies as a person of color. We know that given some of the legal and socio-political influences that our community faces unique challenges. Many of them are living alone, and often this affects their access to things like social supports. We also know that they're more likely to be single and to not have had children. And then also these aspects compound things like poverty. So we know that at least 1/3 of the community is living at or below the 200% federal poverty level. When we think about successful aging, pieces that are really important are things like economic security, access to social connections, and being able to promote your health and well-being. We see these as unique challenges for LGBTQ plus older people. Next slide. So specifically, some unique concerns I mentioned around not having protections for housing. So many LGBTQIA plus people, especially around their economic challenges, but we know that they have challenges in accessing affirming, welcoming, and affordable housing. So you'll be hearing more from Kathleen, who will talk about some of the amazing work happening at Open House. But here I show just an image of some of the progress that we're seeing across our country in terms of states that have LGBT elder housing. Next slide. So caregiving is also a concern for the community. I mentioned around access to social supports. So we know that at least 1 in 4 LGBTQ plus people are currently a caregiver, and these caregivers experience discrimination. Many providers are based in religious institutions, or they have really outdated training and supports that have not been welcoming to the community. So there's some major concerns, and the community is very fearful about needing to access long-term care. These slides come from AARP. Next slide. So another concern for our community comes with memory loss. We've done some research showing higher rates of memory loss in the community, nearly 1 in 7, compared to around 1 in 10 for non-LGBTQ+ people. We also see that these concerns are higher for transgender people of color. And then when it comes to, I shared all the challenges. If a person is living with dementia, they face unique challenges economically as well as accessing care. So next slide. We also have shown some research showing that the community is reporting more concerns with discrimination. So specifically, we have some research highlighting that transgender people are fearful of accessing care because they've experienced discrimination in care settings. This creates major problems when we think about preventative care. And we've also shown that LGBTQIA+ people living with Parkinson's report more discrimination when accessing care. So major concerns when we think about aging and well-being for the community. Next slide. So we need greater representation of our community, both in workplaces. We need to think about training our providers, our service providers especially, and addressing the discrimination that our elders face in healthcare, accessing services, housing, jobs, etc. We need more affordable and welcoming housing for the community, and we need to support our caregivers, especially families of choice, and make sure we can address the unique needs of our community. Next slide. So these are my acknowledgements, and next slide. So thank you for having me, and I look forward to our discussion in a bit.
Thank you, Jason. I think I'm going to launch in. So I'm Sean Cahill. I'm director of... Hi, Matthew. You're going to introduce me?
Yeah, I'll start us off. Yeah. And I'll get to you in just a second. But hi, everyone. Thanks for joining us for our panel today. My name is Matthew Phan. I'm a program associate here at the Center for Healthcare Strategies, and my pronouns are he, him. I'm incredibly excited for this discussion today on opportunities to improve the delivery of and access to healthcare and social supports for LGBTQ+ older adults. We'll be joined by Dr. Jason Flatt once again following that amazing presentation, and I have the pleasure of introducing 2 additional panelists. So joining us today for our discussion are Dr. Sean Cahill of the Fenway Health Institute in Boston, Massachusetts, and Dr. Kathleen Sullivan of Open House right here in San Francisco, California. And so with that, Dr. Cahill, I'll now turn it over to you for your opening remarks.
Thank you, Matthew. Hi, everyone. I'm Sean Cahill, and I work at the Fenway Institute in Boston. We are the research, education, and training and policy arm of Fenway Community Health Center. We're a health center and an HIV clinic, and we have about 35,000 patients. And our specialization is LGBTQI+ health and HIV and STI prevention and care. So I'll just mention a few things in my opening remarks. The first is how important Medicaid is for people living with HIV and for transgender people in particular. So prior to the Affordable Care Act, it was really difficult for people with HIV to get health insurance and to get health care. Thankfully, with the expansion of Medicaid in most states now, a lot of people living with HIV are now on Medicaid. About 40% of non-elderly people living with HIV are on Medicaid, compared to 15% of the general population that does not have HIV. People with HIV are more likely to be dual eligible, in other words, on Medicaid and Medicare, and to qualify based on disability compared to the general Medicaid population. We also know that a lot of transgender and LGBTQ people are on Medicaid, partly because as a group, we're more likely to be low income. And an analysis of transgender people on Medicare conducted by the Office of Minority Health at CMS found that transgender people were more likely to qualify for Medicare based on disability. Many of them were dual eligible, and they had multiple chronic conditions at higher rates than other people on Medicare. So next slide, please, Matthew. So I'm going to talk a bit about some innovations we've been able to achieve here in Massachusetts. We have a project in Massachusetts called the LGBT Aging Project, which has been around since 2001, and it's led by Lisa Krinsky. And Lisa has actually played a key role, as well as Dale Mitchell and others, in helping to achieve a lot of the policy innovations you see on this slide. These include the nation's first statewide LGBT Aging Commission. I serve on this commission. We're called the Special Legislative Commission on LGBT Aging. We've been around for 9 years now, and we were the only one until last year when Illinois created a statewide LGBT Aging Commission as well. Our Elder Affairs Department designated LGBT older adults as a population of greatest social need under the Older Americans Act in 2012. This is significant because it means when they re-grant Older Americans Act funds through the state Elder Affairs Office, through the area agencies on aging, they ask groups that are applying for the funding to say how they're going to provide services to LGBT older adults. We have also been collecting sexual orientation and gender identity data. Our Elder Affairs Department has been collecting such data since 2016. There's still some kinks that need to be worked out in terms of implementing the data collection, but it has been underway for several years now. And since 2018, all elder service providers in Massachusetts must be trained in LGBT cultural competency. I just wanted to respond to Carrie. Carrie mentioned that maybe Massachusetts has a long-term care bill of rights. We actually don't. Legislators introduced such legislation in January, and we are advocating for its passage, but we don't have the law yet. We modeled our law after a law passed in New Jersey. And basically what it does is it sort of enumerates what non-discrimination laws mean for people in nursing homes, assisted living, long-term care, and rehab facilities. So we have public accommodations non-discrimination, we have healthcare non-discrimination, and we have housing non-discrimination. But this bill would enumerate explicitly what does that mean for different aspects of living in a long-term care facility. Another thing that we've had happen in Massachusetts, which we're very excited about, is on the final slide that I have, which is that our MassHealth, our state Medicaid department, sought an 1115 waiver last fall, which will include a $2 billion incentive program over 5 years to hold accountable care organizations and ACO participating hospitals accountable for reducing disparities in healthcare quality and access. And it's explicitly requiring that providers collect a number of different kinds of data, including race, ethnicity, but also sexual orientation and gender identity, and report that back to the state and basically try to reduce disparities affecting LGBT people, Black LGBT people, Hispanic LGBT people, and so on. That's really exciting. I'll mention one last thing. So we are seeking to get our state legislature to designate LGBT older adults and older people with HIV as populations of greatest social need under the Older Americans Act at the state level. We have it for LGBT people, but it's at the executive branch level, and we'd like to get it legislatively because that's harder to overturn. But at the federal level, the Administration for Community Living put out a proposed rule last month, and comments are due in mid-August, and it would designate LGBTQI plus people and older people with HIV as populations of greatest social need under the Older Americans Act at the federal level and under state aging departments and under AAAs. So that's something that I encourage you to submit a comment on and in support of, and thank you very much.
Thanks so much, Dr. Cahill. And now I'll pass it over to Dr. Sullivan for some remarks as well.
Good morning. Thank you all for being here. And I'm just following the footsteps of giants, both Jason and Sean. So I appreciate both of the presentations today. I'm going to talk a little bit about open house and then really hone in on And Angela, I think you asked a great question in the Q&A about the importance of this work and really continuing this work and seeing how we can really leverage Medicaid to better serve the LGBTQ plus community. My name is Kathleen Sullivan. I'm the executive director of Open House. My pronouns are she, her, and Open House is in its 25th year. We started as a housing organization and really looked to build community through developing affordable housing that was welcoming to LGBTQ elders. Affordable housing takes a while to build, and as such, we found over time that there was a great need in San Francisco to provide services, both educational enrichment services where people could be in social settings and come together to share community, but also to provide case management, housing navigation, sort of the suite of services one would expect from a social service agency. We did that and really built out our programming as we were developing affordable housing. And right now, Open House has 2 affordable housing communities, and we are in pre-development for our 3rd in San Francisco. Those housing developments are great. We can never build our way out of the need for housing. And in San Francisco specifically, older adults are the fastest growing population who are represented in the houseless or homeless population. We really did go very deep and long in creating our programs and services. We have a great team who provide community support services. And last year, particularly due to the recognition of the disparity in health and mental health for LGBTQ elders in San Francisco, we also have just started to build out our mental health services program as well. That's incredibly important. And Jason alluded to this, as did Sean, that a lot of LGBTQ elders find that accessing care can sometimes be at the smallest level a discomfort, but also can be dangerous for them based on discrimination, marginalization, not feeling safe, and oftentimes having to feel like they're taking care of their provider when they disclose their sexual orientation or gender identity, as opposed to getting care from their provider. Because we work with so many organizations within the San Francisco Greater Bay Area, we also built out in 2012 a really robust training program. That's a cultural competency training, similar to what Jason was discussing earlier, but also now have evolved into a clinical training and are literally in the process right now of creating an online academy. So Angela, that's one thing. In August, Open House will have our online academy up for beta testing, and it will be something that will get updated and people will have the opportunity to interact immediately with trainers, which will be great because there will be a Q&A. It will be very open and responsive to folks. Why should all of you care about this? We know that LGBTQ elders oftentimes will postpone or delay treatment, and unfortunately that means that a lot of care then will take place in an emergency room, and situations can get they can get worse in terms of healthcare, as opposed to if people were taking care of issues or problems that they had earlier on in their care need. I think also, in Medi-Cal and the expansion, particularly here in California, it's important to note that we have some great laws on the books in California for sure. People have referenced the Bill of Rights we have for long-term care. That we Open House, along with the Department of Aging in San Francisco, wrote the Bill of Rights along with Senator Weiner and Daniel Redman. And we have to revise it because in California, it is now, according to the Third Circuit Court, legal to both dead name and misgender an LGBTQ elder who's in a nursing home or assisted living community. So that's something that is at our Supreme Court right now, but just ensuring basic dignity and basic human rights for our patients, for our community members that we serve at Open House means we're creating a more robust, but also a program of services and service provision that is really meeting the needs of not just LGBTQ elders, but really all of the elders that we serve. In San Francisco, we see an enormous amount of food insecurity. We see an enormous amount of mental health issues, but then also people that need more care based on their cognitive ability. And we did partner recently with an organization called Unlock in San Francisco and host a community day service program as well as an alternative healthcare setting. And that really allows for caregivers in particular to know that their LGBTQ elder is going to be safe. Our day program is a full day program with meals and activities. And so for those who need a little bit extra care, who have cognitive impairment or may also have physical challenges, the day services program is a great added benefit. It's still the first in the nation, and there's going to be a lot of learning that Open House has over the course of the next several years, and we'll be sharing that. We want to be able to expand this type of program and service to more seniors throughout the country. So as soon as we know more, we will get that information out. And we're very fortunate that Dr. Flatt actually is helping to evaluate that program. I'm going to stop for now. That's just a brief introduction and pass it back, I think, to Matthew, if I'm not mistaken.
You're correct. Thanks, Dr. Sullivan. As a reminder for all attendees, feel free to use the Q&A section in the Zoom toolbar at the bottom of your screens to ask your questions. It's a little Q&A that you see in that slide right there. During this session, we'll try to answer as many of them as possible. And now at this time, I'll invite all of our panelists to come off camera for this amazing panel discussion. So as questions are coming in, let's start off with our first question. As Carrie mentioned, some CalAIM initiatives are focused on better addressing the social needs and long-term supports and services for older LGBTQ+ Medi-Cal enrollees. Given all that California and other states are doing to address health-related social needs in LTSS, what do you see the value added being for contracting with CBOs to provide culturally responsive services or conduct trainings?
Matthew, I'll volunteer a couple of thoughts. We do a lot of trainings with elder service providers at the Fenway Institute and the LGBT Aging Project. And, you know, one of the things that we get often is we treat everyone the same. Why do we need to, be trained in the unique experiences and needs of this population? Or, or we'll hear people say, sometimes from rural parts of the state in particular, we don't have LGBT clients, And so we emphasize that they probably do, and they might not be out. And it's better to create an environment where they could be out because like in terms of healthcare, if you can be out as a trans person or a bisexual person, you're more likely to get the care that you need and the services that you need. But I would say also that partnering with a CBO, like Jason mentioned, there's medical mistrust and it's related to negative experiences with the healthcare system that a lot of people have had in our community and continue to have. A lot of people of color experience racism in healthcare. And so that causes them to have this medical mistrust. And by partnering with a CBO that has established a relationship of trust with the community, that reflects the community, that represents the community, that's sort of embedded in the community, it can help you to actually reach people who you might not otherwise be able to reach as a service provider.
I would just, thank you, Sean. I would just also highlight that treating your patients, your clients with respect and dignity is really all that our trainings are asking for. There's some clinical issues, particularly for transgender elders, but ultimately it's about treating people with dignity and respect. And as someone who's worked in large organizations and small organizations, the worst thing you ever want a manager to say is I treat all of my staff the same, because all of their staff is different, just like all your clients are different. So having some training, having some knowledge, and there are lots of organizations throughout the country that provide it. The LGBT Aging Project, part of the Fenway Institute, was one of the first that really put together a comprehensive training program, but there are others across the United States. Having that training helps you to have a better understanding of the lived experience and how a person is coming into the care environment. Knowing who the social support network is of a patient is critically important, particularly for aftercare. And there's been tons of research, and Jason can probably point to this, of providers not knowing the aftercare plan for an LGBTQ elder, but having that aftercare plan for a heterosexual counterpart. And so, the more we can do to ensure that our care is comprehensive and meeting the needs of our patients or community members, the better that care is.
I'll just add, I think one of the strengths of this is you want to learn from someone that's doing it well, right? That knows how to meet the needs of the community, understands, has trust, right? Has experience providing services and care. I think that many healthcare and social care providers have good intentions, but their lack of knowledge, but also their lack of comfortability with serving the community creates a lot of these problems. And so I think that working with those that know how to do it well, have trust, know the best practices, but also are committed to supporting the community and can be a resource to you long term. And so I think that those are really the value of it. And really, we need more organizations to really be working with, community-based organizations that have expertise and are already meeting the needs of our LGBTQ plus seniors.
Great, thank you all so much. Dr. Cahill, I want to hop back for a second to a topic you mentioned earlier, which is LGBTQ older adults in rural areas. We know all too well that's too frequently underaddressed. With all the training CBOs, those ones too frequently are not in those rural areas. So how do we go about addressing the needs of LGBTQ older adults in these rural populations?
Yeah, it's very important. We did some research. We actually did a series of listening sessions around the Commonwealth of Massachusetts in 2019 and 2020, and we eventually switched to virtual listening sessions. But we did several of them in rural parts of the state, and we found that people, even in a relatively liberal state like Massachusetts, where we've had a gay rights law since 1989, a sexual orientation non-discrimination law, that there's still discrimination. So people reported experiencing discrimination in the Berkshires, in Pittsfield, Massachusetts, way out by the New York State border, in healthcare, in private businesses. And it was actually two women who said they were cisgender lesbian women who were kind of basically sexually harassed. They were referred to as men, and it was in a harassing way. They don't identify as men, they identify as women, they're cisgender women. And so that's one example. There was also a guy who was in a long-term care facility, and his husband came to visit and took him out for a walk. And when he came back, there was a police officer waiting, and somebody at the facility had accused him of sexually assaulting his husband while out on the walk, which is insane. But that's sort of an example of the hypersexualization of gay men, which sometimes happens. And then the other example I remember was a guy in just a senior housing development in rural northern Massachusetts by the New Hampshire border, and he made the mistake of coming out to another person in the facility, in the housing apartment building. Next thing you know, everyone knew he was gay. Everyone started, and it was mostly women, straight women, and they basically just started saying really mean things to him and harassing him because he was gay. So those are just examples of how discrimination happens. I think it's important that the attorney generals at the state level, enforce non-discrimination laws, that they encourage people to report experiences of discrimination, and that service providers know that and train their staff in how to, send a message that they won't tolerate discrimination, that the service provider is a safe environment, but also to intervene if they see other age peers engaging in discriminatory behavior, because that does happen. Sometimes people say to us, it's kind of like going back to junior high school when you go to a senior center or you're living in some kind of senior housing facility. You know, it's like going back to your adolescence when people were bullying you, and that shouldn't be allowed.
So on the same vein of that, I have a great audience question for you all that ties quite well into what we're talking about. An audience member asks, we're hearing from states that are largely supportive of the LGBTQ plus community, but what can be done for people in states that are hostile to this community?
I think a big piece will be identifying resources in those communities, places where people can access, you know, affirming care, affirming providers, safe space zones. That may be in non-traditional spaces that you wouldn't really think of. It could be like, you know, in a church that's affirming to the LGBTQ plus community. It could be accessing your local LGBT center. And it's also, you know, it may require you to leverage some of the resources that are available nationally, whether that's with like an organization like SAGE or looking at aspects, you know, globally, like you've heard from, you know, Fenway Health and Open House can connect people to services, even if it's outside of their region. And so that's important to really think about.
And I think if you're a provider, it's a great points, Jason. I think if you're a provider in one of those states who is very interested in serving this community, spending time to develop trust within the community, that you're a trusted partner, you will be a trusted provider. And you can demonstrate that by getting training yourself for your staff and really being that beacon, because what we know is as these political tides are going back and forth, things change. And, you know, I believe after working in politics for many years that we will get to a point where this current wave, as disastrous as it is and as hurtful as it is to so many people, it will be you know, be a thing of the past soon. So that's my 2 cents.
Yeah, I would say make sure your organization has a sexual orientation and gender identity non-discrimination policy. Make sure that your staff are trained that it exists and what it means and how to implement it, how to have it be a living, breathing thing. And then also, you know, think of ways that, you know, you could live in Texas, but, you know, if you live in Harris County, I was trying to remember where Houston is, Harris County, you know, you could work to get a non-discrimination ordinance passed at the county level. They used to have one. It got voted out by a ballot campaign a few years ago, but certainly promoting local non-discrimination ordinances can be helpful. Also think about what professional associations are you a member of, because you can work to ensure that your professional association, you may be able to put out a statement about the importance of non-discrimination or in support of gender affirming care. And also you can engage with your state government as well. And you can testify as a service provider, as a healthcare provider, in opposition to anti-LGBT policies. So so don't give up just because you live in a state that's predominantly, you know, opposed to equality for LGBT people, because it doesn't necessarily have to stay that way.
Great, and that's actually a perfect segue into my next audience question, which is on SOGI data. So what do you think is the importance of collecting this data in both clinical and social settings? And what are some best practices that clinicians can be mindful of when collecting SOGI data?
Well, I'd say the first thing is collect it for everybody. Don't assume that you know someone's sexual orientation or gender identity. You know, I do think that it does require a little bit of training, not a lot, but what we don't want is for you to ask for someone's sexual orientation or gender identity, for that person to then disclose, and for you to say, oh, it's okay, I treat everybody the same. What does that mean, it's okay? That means maybe with other people here, it's not okay. Why is this scale being placed on a part of who I am as a person? So get a little bit of training for yourself as well. And, you know, the importance is that without data, there can be no true equality. We need to know, who are we serving? And it helps to really gauge, are there things that we need to do differently? Do we need to improve? If we're seeing a number of people after, your organization gets trained on working with LGBTQ elders, all of a sudden you see, oh, we're providing services to more LGBTQ elders. Maybe that shows you there was a need in this community that we weren't reaching before. So there's a variety of reasons to include SOGI data. Certainly at the state level, it's incredibly important when looking at different policies. And I think that there's a need, certainly in California, to ensure that the collection of SOGI data is consistent across departments. And that's something that we have not fully been able to implement now. So there's some departments that are great, some that are not as great. But it will do a lot to really tell us more about who is it that we're serving, and maybe what other specialty training do we need to make sure that we're giving competent care.
Matthew, I would say, if you don't count us, we don't count. So if you don't collect the data, we don't know anything about the population that we're talking about. We know, because we ask SOGI on our behavioral risk factor survey in Massachusetts, that LGBT people aged 50 to 75 are twice as likely to be depressed as straight cisgender people 50 to 75. They are about twice as likely to fall in the past year and be injured in a fall in the last year. They're 3 times as likely to struggle to put food on the table or pay rent. Those are just a couple of examples I remember from an analysis we did recently. The other thing is and we know that, like, in the older age cohorts, where maybe 3%, 4% of people in their 60s and 70s are LGBTQ. With younger age cohorts, it's more like 15, 20%. But we're still there. We're just a small minority. But it means a lot to people who are LGBT when you ask them in a respectful and culturally responsive or culturally affirming way. It sends a message that you get it, that you understand the importance of collecting the data, so you know the population that you're serving and how they're experiencing elder services, or what kind of health issues they're experiencing.
And make it a routine part of your asking about people's backgrounds, right? So that's where you should ask about it. When you're asking about race, ethnicity, about specific pieces, that's when you ask it, right? And it may be important that you ask it again. We do know that sexual orientation and gender identity do evolve over the life course. So it may be important to ask it again. It's not just like a one-time do it on the demographic survey and never ask again. So it should be a part of sort of the routine when you're collecting information, background on your patients, those you're serving, or if you're a researcher, right, asking these questions. It's so valuable, and you're going to learn a lot. And there is work out there around best practices. So I definitely encourage to learn about that, follow some of those methods around collection of SOGI, sexual orientation and gender identity, and be willing to ongoingly learn. This changes as our community's sort of knowledge, but also experiences change. You have to update language on your forms to make sure they're truly inclusive and welcoming for all people. And I always say that if you do this, it makes care welcoming for everyone. And that should be your goal.
Perfect. And then so in recognizing time, I want to do one last audience question. This one's very important, one that is very timely. Does the panel have any thoughts on how to advise LGBTQ older persons to better plan and prepare for healthcare, financial, and social care needs as we age?
I think there's some really important discussions we do need to have with our seniors around end-of-life care, right? Advanced care directives, some of those pieces that are important so that their wishes can be honored. So those discussions need to happen. I would say leverage some of the resources in your community. So we talked about working with CBOs, and I would say reach out to CBOs to find out, right, who is providing services for the community, who can help provide some of that guidance around planning for healthcare, planning for some of the unique needs that the community may have.
Yeah, I totally endorse everything you just said, Jason. I think the other thing is because you might not live in an area that actually there might not be a CBO that's actually providing competent care, is if possible, create cross-generational relationships so that you can really advocate for the development of programs and services for LGBTQ elders. I think it's incredibly important to find healthcare providers and mental health providers that are supportive of you and advocate for yourself. If you need to have someone go with you, we have a program called the Friendly Visitor Program, and our friendly visitors are there to really support the elder and in all aspects of that person's life. So ensure that you have the support you need if you're going in to meet with a new provider before, you might have a traditional checkup. You can have someone with you and sort of talk through what's important to you and have that person be supportive. I also think that it's very important for our community to be, just start thinking about what are the long-term care needs. So, one of the struggles we have with our community day program is some people feel like, oh, I'm not old enough to need that level of care. And really, when we evaluate that person, they need an enormous amount of care. They might have some cognitive decline, they might have some physical decline. So I think that we're maturing as a community and really starting to have these conversations for the first time. So being open to that, the natural changes of aging, educating oneself, I think those are all important things as well.
I think you're on mute, Matthew.
I was muted, yeah. At this time, I'm getting the 2-minute warning from the big boss, which means it's time to wrap up. So with that being said, what final remarks or considerations would you like to leave our audience with?
Thank you for being here and your commitment to learning and your commitment to supporting LGBTQ plus seniors. I'm really grateful to be a part of this panel, and I want to thank our audience for being here and being open to learning.
I would say the same thing. So grateful that you're all here. And I would say, if you are just in the learning process, just beginning the learning process, it's better to make mistakes and acknowledge them, because that's how we learn. And I think that one of the challenges when I do go out and do trainings is people feel like they don't want to make a mistake. And so they never change their practices or their behavior. Language is the single biggest behavior that you can change and demonstrate that you're being welcoming and accepting of others. So that's what I would leave you with.
I'll just say, echo what everyone just said, and thank you, but really thank you for all the great innovation that you're doing at the state level, at the local level. There's so much great work happening in California and in other states around the country, and at the federal level right now. There's a lot of great things happening within HHS, within the Administration for Community Living, and it's exciting. It's going to make people's lives better.
I want to give one last thank you to all of our panelists for being here today. This was such a great conversation. But at this time, I'll turn it back to Carrie to close out this webinar.
Well, again, just thank you to all of you for being here. Thank you to our wonderful panelists. We will be publishing a fact sheet on addressing health, LTSS, and social needs for LGBTQ plus older adults at CHCS. So we'll be advertising that soon. And I also just, in addition to being here, I really hope that everyone will fill out, we'd like to hear what you think of this session. And so very interested in having you fill out the evaluation survey. Thank you so much.